They are automatic reactions that serve to people to maintain and restore the normal body alignment in space. And as I said, they develop in the childhood are modified and integrated into complex activities of equilibrium reactions and voluntary movements. And they are essential in building up motor patterns for adult life. That's why when you move to the left, these writing reactions automatically bring you to the midline position. And when you are moved to the right or left, these reactions automatically, without thinking about it, without any attention to these conditions, these reactions bring you to the midline position. When you move forward or backward, again this reaction works. With eyes closed, with eyes open, these writing reactions work to keep our body alignment in the normal position.
And automatically, if you, for example, falling to left side, automatically you will use the left side to protect yourself.
Come here, please. Stand there. Remember, you are playing with your child. You move it to the right and left. With maturation of CNS, they appear after spinal and brain stem reflexes that are integrated. The midbrain reflexes, such as writing reactions, reappear. When eyes are closed or open, when you move it to the left, these reactions help him to come to the midline. Or when you move it to the right, he will come to the midline position. Forward and backward also elicit these writing reactions to keep the body aligned in the midline. Close your eyes, please. When you move it to the forward, he will come to the midline, aligned with the body segments to be aligned in the midline. Left, right, any displacement of body, center of gravity to different direction will elicit these reactions to bring the body to the midline position. All right? But when you disturb the body position significantly like this, it will show the equilibrium reactions with stepping forward. It's an equilibrium reaction. Also, these equilibrium reaction, are integrated in the highest level of CNS, cortex. Therefore, again, without thinking about the reaction, when I move the body forward significantly, changing the center of, moving the center of gravity beyond the base of support, he will show different equilibrium reaction to keep the body balanced. Writing reactions is before the equilibrium reaction appear to keep the body in the base of support, to keep the center of gravity inside the limitations defined by the base of support. But when the changes in the position of body that move the COG beyond the base of support, the equilibrium can be occur. For example, dorsiflexion of the ankle, as you see, please pay attention. See the ankle of Alreza. He uses automatically dorsiflexion to keep the body balanced. Is an equilibrium reaction. Or when move Alreza forward,
using toes.
Automatically, without thinking about it, plantar flexion of the ankle occurs to keep the body balanced and to keep and maintain the balance. And when disturbed, perturbated, using these reactions will help the body to keep and maintain or restore the balance of it. These are integrated in highest level of the CNS, highest level of the CNS, I mean protein. Therefore, after writing reactions, when they are not enough, they are not sufficiently help the patient to keep the body aligned, keep the balance of the subject, equilibrium reactions will come to help the subject. Therefore, they are also equilibrium reactions, are also automatic reaction. They are integrated in the highest level of the CNS cortex and serve to maintain and restore balance during all activities and involve the patterns of writing reactions, I mean head control and rotation of the trunk and pelvis. As you know, all these equilibrium reactions with tonus changes, postural tonus changes, and movements are well coordinated, quickly occur, adequate range and well timed to maintain the balance of the subjects. Therefore, postural reflex mechanism consists of writing and equilibrium reactions. And equilibrium reactions are the first line of the defense against injury. Remember that. Don't forget that equilibrium reactions are the first line of defense against injury. But when equilibrium reactions are not sufficient to maintain or restore the balance of the body, you may experience the following. In these conditions, protective extension, the parachute reaction, comes to action to help the subjects, to help them not to face injury to the faces and body. Therefore, after equilibrium reaction, when they are not sufficiently to help the balance of the subjects, parachute reactions or protective extension of the arms come to action that help the subjects not to face injuries, especially to the face. Therefore, parachute reaction or protective extension of the arm is the second line of defense against injury. When I cannot control my balance, I will experience falling like this. In this way, I extend my arms. This reaction is protective extension of the arms to help to parachute reaction is this one is parachute reaction or protective extension of the arms to help the body not to be injured by falling. Therefore, parachute reaction after equilibrium reaction is the second line of defense against injury. What do you see here? What's that? What reaction you observe here with this child? He fell down. What happened here?
Crying. He extended his extension of his arms.
Extension of the arm. He used automatically extension of the arms to keep the face not to be injured. Make to using this protective extension of the arms to help not to be injured, especially the face, help the protect the child, of course, the face of the child from injury. Therefore, these reactions, probably you all have experience with parachute reaction or protective extension of the arms to help to protect the face from injuries. Therefore, here, this child used his arms and hands to protect the head and face from the injury. Therefore, Bobat assumes that after spasticity prevents from this automatic reaction to occur. Therefore, prevents automatic reactions from functioning, especially on the affected cell. Therefore, due to the lack of this reaction, these reactions on the affected side, patients with a stroke are reluctant to carry their weight on the hemiplegic side in various positions, sitting, standing, and walking.
Doctor, what's the reason or origin of these reactions?
This reaction, as I said, it's a natural process of maturing of the CNS. With the maturation of CNS, these reactions from spinal level to the cortex level, the various reflexes occur before the children to be able to make voluntary movements. In fact, these reflexes help the children help the children to perform some necessary movements that are vital to their survival. Therefore, with the maturation of the CNS towards the ability to perform voluntary movement, these reactions help the children to be able to perform some automatic reaction. But some of them remain life forever. For example, writing reactions, equilibrium reactions, or some, especially the reflexes associated with the interaction of cortex always remain and act in various conditions. For example, parachute reactions appears in 6 months after childbirth and remains forever. Writing reactions and equilibrium reactions appear with when the CNS matures to the level of midbrain after spinal and brain stem maturation. When the CNS reaches to the midbrain level of maturation, writing reaction appears, and these reactions always act when the child grows up into the adulthood. Therefore, some reactions, some reflexes are integrated, such as the lower spinal and brain stem level reflexes, such as asymmetrical tonic neck reflex, symmetrical TNR, positive supporting reaction. They are integrated, but they are not lost forever. But they exist even after sufficient maturation of the CNS. With injury to the CNS, they will again reappear to help the subjects with injury to their CNS to help the patient to act some movements, even reflexively. Therefore, these reflexes appear during the maturation of the CNS with growing of the child. You will learn all these reflexes and maturation of the CNS and how to test these reflexes in PT neurology 3, I think.
So, doctor, how that's possible? How these reactions remain forever, even if the person gets a stroke or?
As I said, this is the natural for the CNS. They are genetically programmed. All right. These reactions that remain forever are genetically programmed. All right. We cannot make it. They are genetically programmed. All subjects experience this. When growing up, when CNS matures, when the brain matures, these reflexes appear and reappear. Appear, disappear, and may reappear again, especially when there is an injury to the CNS. Therefore, we cannot make these reflexes. They are genetically programmed for the human beings. All right? But I said, Bobat assumed that after stroke, the major problem is spasticity. The spasticity of the muscle on the affected side causes these reactions, normal reactions of writing and equilibrium not working on the affected side. That's why the people with the stroke are reluctant to shift their body towards the affected side. Therefore, they are trying to be dependent on the seemingly intact side. That's why they are reluctant not to carry their weight on the hemiplegic side in sitting, standing, and walking. But automatic adaptation of muscles to postural changes is the third component of postural reflex mechanism. All the time, dynamically, our postural tonus changes. You are in a sitting position, but all the time you are moving. You assume a posture set to have a comfortable position. And these continuous posture set of the posture is associated with adaptation of postural tonus of the muscles. But again, it's subcortically integrated. You don't think about these postural adaptation. My postural tonus of muscles all the time are changing and adapting to the condition because I'm standing, I'm walking, I'm talking all the time dynamically. These postural tonus are changing and adapting to the context, the condition, to meet the requirements of the body in various conditions. Your requirements are different from me, that I'm standing and walking and talking to you. Therefore, all adjustments occurs. Automatic adaptation of muscles occur to postural changes. This postural reflex mechanism equals to central postural control mechanism and postural adaptation to gravity, or in simpler terms, it's a postural reflex mechanism with writing reactions, equilibrium reaction, and automatic adaptation of muscle tonus to the changes in posture. And this mechanism is assumed by Bobat that governs the weight of a limb during movements into and against gravity. If I can normally bring my inflection against gravity or towards the gravity, I control all stages of movement is due to from postural reflex mechanism. On the affected side after stroke, they cannot control their body against gravity and towards the gravity. If you raise their arm into abduction, if you drop it suddenly, it will drop like this. But in normal subjects, if you suddenly drop the arm from this position, it will not drop. But a little bit drop, you control it and bring it slowly to keep it alongside the body. And this is performed by the postural reflex mechanism. This test I showed it to you is named placing maneuver. Raising the arm into abduction, 90-degree abduction, and dropping suddenly. In patients with hemiplegia, they cannot control the dropping of the arm from the abduction position, like this. If they cannot control the dropping arm from abduction, indicates the on function of the postural reflex mechanism. If you can control it, this indicates that this postural reflex mechanism is working normally. Therefore, placing, as I said, normal person, therefore is active when being moved against gravity or towards the gravity. And normal subjects can control every stage of movement actively and automatically. You don't think about it. If I drop your hand, come here please, Aliana. All right. I dropped it, but he controlled it. Why? Because this mechanism is working, postural reflex mechanism. It's the placing maneuver, it's a test that's also used in treatment of patients with nerology. All right, again, he controlled the movement actively, but without thinking about it. All right, if I blindfold the eyes, all right, and bring it up into abduction and drop it, it will not drop. It's controlling automatically without conscious focus of the brain, without mentally activity. Without mental activation, he can control the arm movement towards the gravity. This is named placing maneuver. He's a normal person, all right, because he controlled the dropping arm from abduction into abduction to keep the arm alongside the body, all right. Therefore, he, as a normal person, controlled all the stage of movement actively but automatically. All right? Bobat assumes that normal posture control prerequisites for voluntary functional activity. To be able to act normally, to have normal movements, performed voluntarily, normal postural tonus must be in moderate intensity. Interaction of the muscles must be existence and to be normal. And automatic movement of the writing and equilibrium reaction must work. All right, I'm asking you what reactions this trapeze is eliciting in this subject. Let me know your name, please. All right. What reactions are elicited here?
Writing reaction.
Writing reaction. He moved it toward the left side, but he is trying to come to the midline position. He is moving the subject towards the left side, but the patient, the subject, is using writing reaction to come to the midline position. If you move me to the left, I will come to the midline position. If you move me to the right, I will come again to the midline position. Eyes open or eyes closed. If you move me to the left, I will come to the right. This is a writing reaction. And this trapeze is eliciting the writing reactions. All right, normal, based on the normal reciprocal innervation, all muscle groups with various functions are in interaction with each other, interact with each other. Therefore, the normal interaction of muscles are necessary for normal movements because some act synergistically to fix the proximal segment to help the subject selectively move the distal segments. Fixators posturally act to keep the shoulder orange, the elbow, shoulder and the elbow in, for example, extension position to be able to move the wrist and finger. Therefore, the proximal segments fixed, but the distal segments move. And this is due to the interaction of muscles with various functions. And for normal movements, automatic adaptation of muscles with for postural changes are required. All this help for the timing and direction of movement to be normal. But what happens after stroke? What happens after stroke? Stroke causes disturbance of normal postural reflex mechanism. Therefore, disturbance of the normal postural reflex mechanism indicates that it's abnormal. Normal postural reflex mechanism is disturbed after stroke based on NDT approach. Therefore, clinically we will have spasticity in these patients. That will cause the postural patterns to be restricted to static and stereotyped mass movement patterns of flexion and extension. And the patients are restricted to these flexion and extension mass patterns. Therefore, in summary, NDT's view is that stroke causes the release of abnormal postural reflex mechanism. Release of abnormal postural reflex mechanism. Again, those low-level reflexes of spinal and brain stem again reappear, making the abnormal postural reflex mechanism. Therefore, static postural patterns are exaggerated and writing and equilibrium reactions are lost. Any question? Any question? I'm asking you one question. According to NDT view, what's the mechanism in normal subjects to be able to perform, to function normally? According to Robert approach, what mechanism is working, acting to help the normal persons to function normally, to perform movements normally? Postural reflex mechanism. All right. Let me know your name. Ali.
Ali Namir.
Ali. That's right. Thank you. All right. Now the components of abnormal postural reflex mechanism. What do you think about the components of abnormal postural reflex mechanism? Instead of normal postural reflex mechanism, after stroke, they will have abnormal postural reflex activity with these components. Associated reactions, asymmetrical tonic neck reflex, and positive supporting reaction. What test is it? Alireza, what test is it? What reflex this child is demonstrating?
Equilibrium reflex.
Zainab, what reflex this infant is showing to us? Is the positive reaction of a reflex that's integrated in the brain stem level. This shows that this infant is growing up and his CNS and brain is maturing, is evolving.
Writing.
Not writing.
Automatic adaptive.
No. What
Or,
brain, what brain stem reflex level it is?
parachute reaction.
Partial reaction uses the arm extension, both arms, like this one, to protect my face when falling. No idea? I forgot your name. I'm waiting for you to give the correct answer. No idea?
Neck reflex.
Asymmetrical tonic neck reflex. All right? After stroke, all these infancy reflexes appear again. Associated reactions, asymmetrical TNR, and positive supporting reaction.
So that's normal reflex, not abnormal.
Is normal reflex for that person, for that infant, for that child. All right, but not normal for a stroke, for an adult with a stroke. For that adult stroke, adult patient with a stroke, this reflex is abnormal. This reflex cannot be elicited with you as a normal person because it's integrated. Yeah? The higher level of CNS, cortex, controlling and inhibiting all these primary reflexes. Asymmetrical TNR, symmetrical TNR, positive supporting reaction, and associated. All these reflexes are integrated, are not lost. That's why they appear again with CNS injury, such as stroke. Therefore, associated reactions, asymmetrical TNR, and positive supporting reaction again can be observed after stroke that these components make the abnormal postural reflex mechanism. Therefore, remember from the prior session that associated reactions are tonic postural reactions in paralyzed muscle, and associated reactions are associated with spasticity. With severe spasticity, associated reactions will easily be elicited. Therefore, with associated reactions and spasticity, movement will be stopped and reduced. And associated reactions will increase the severity of spasticity. And if not controlled, can cause pain, contraction, and frontal deformity. Therefore, do you remember what definition I provided yesterday for you for associated reaction and result? Do you remember it? What in this picture, in this figure, what Tropos is doing?
Stretching the calf or
What? What's she doing here? I define the associated reactions that any new movement, any resistive movement on the intact side will produce associated reactions on the affected side and will increase the spasticity level. All right, here as you see, the tropist asks the patient, all right, is giving resistance to the plantar flexion of the intact ankle. As you see, with resistive exercise, the affected leg assumes the flexion of the affected leg with knee flexion, hip inflection, and the ankle in dorsiflexion. And this is an associated reaction. When performing a resistive exercise on the intact side. And here again, by giving resistance to the dorsiflexion of the intact ankle joint, you see the reaction in the form of plantar flexion and exaggerated extensor tonus on the affected lower leg. Therefore, in summary, associated reactions are found in all patients with a stroke and spasticity. These reactions appear with strong voluntary or resistive activity of the unaffected limbs. As with severe spasticity, the associated reaction will be stronger and will last for more longer time. And if not controlled, can reinforce a spastic pattern, and if not managed, if not controlled, can lead to contractures and therefore deformities. A study found that, a recent study reported that within 6 weeks after stroke, 27% of patients post-stroke will show signs of spasticity. 27% of people with a stroke within 6 weeks after a stroke will show signs of spasticity. But within 6 months after stroke, with the passage of the time, if not controlled, contractures will be appear. This study reported that 52% of people with a stroke develop contractures within 6 months in at least one joint. Therefore, they are vulnerable to contractures. And contractures are a mechanical phenomenon. And spasticity is a neural phenomenon. I'm asking you one question. A patient with a stroke suffers from contracture of the Achilles tendon. A stroke patient is suffering from plantar flexors contractures. Can you prescribe, for example, Botox injection? Can you prescribe using the inhibitory technique of Bobat for such patient? A stroke patient came to your clinic to visit you, to ask you for the contractures of the ankle joint on the affected side. She's asking you, when can I go to the neurologist to inject Botox?
No, we can't.
Why?
Because for for example, you said we can use Bobat approach or not. In Bobat approach, we use active movement, but he have a contracture, so he can't move the limb or arm.
All right. Your friends, your colleagues, all right, may ask you refer the patient to the neurologist to inject the Botox. What will be your answer? Ali Omer tells you refer the patient to the neurologist for Botox injection for his or her contracture, ankle contracture. What will be your answer? Ali Omer?
I said no.
And you, what will be your answer? 1, 2, yeah. What's your name? Yeah, you. Yeah. Right. All right. What will be your answer? Your friend saying refer him to the neurologist for Botox injection, and he will improve after Botox injection. But the patient suffered ankle contracture, plantar flexor contracture. He's sleeping. Ask him to wake up. Remember that spasticity has neural origin. Listen to me, please. Spasticity has neural origin. And the drugs, Botox, and medications prescribed for spasticity cannot be used for contraction. For such a patient, we cannot prescribe Botox injection.
Depends on the reason of
We
contraction.
cannot use neurophysiological techniques such as Bobat approach technique. And for such a patient, we need to prescribe mechanical interventions such as stretching, prescribing splints, braces, and like that to stretch the contracture muscles.
But doctor, I heard about that approach before. We can use the Botox injection and contracture patient.
Just for spasticity. If the original stiffness is spasticity with neural origin, you can prescribe spasticity medications and Botox injection. If you prescribe Botox injection, for example, if it will not be effective
So
because the mechanism of action of Botox is different from those used for contractures.
for example, if their patient have contracture because of spasm or because fracture or something like that, or bad posture, so we can describe Botox injection or not.
As I said, contractures have mechanical origins. And the medications, such as Botox, cannot be prescribed for mechanical origin contractures or short-terms because their mechanism of action is different. For example, Botox reduces the acetylcholine releases, but we don't have problem with acetylcholine releases in contractures. There is severe overlapping of actin and myosin. All right, therefore, to improve the contraction, we need to apply mechanical intervention in the form of static stretching for the long time. All right, therefore, within 6 weeks after stroke onset, 27% have signs of spasticity, but after 6 months, at least one joint of the patients with a stroke and spasticity show and develop, 52% show and develop some contraction. And that's important to be noted when treating patients with stroke and spasticity. But I was like, will you prescribe dry needling for such a patient with the ankle plantar flexor contracture? Will you prescribe?
Yeah.
Why?
For? You mean in the workshop?
Will you prescribe dry needling for contractures post-stroke or post-CNS lesions, for example, MS and other neurological conditions such as cerebral palsy? Will you prescribe dry needling?
No.
Why not?
Because you said previously, contracture is mechanism, not dry, not neurological
All right.
case. So
And what do you think about the answer of others?
Please repeat this.
With dry needling, there is no drug injection.
Mhm.
You mechanically manipulate the
Yeah,
tissues.
we work on receptors, sensor receptors.
Dry needling is important. Have mechanical as well as neural effects. Therefore, you can prescribe dry needling for contraction. Yeah? Medications and injection, such as Botox, uses drugs, all right, to act neurophysiologically. But dry needling has two important effects: acting mechanically with manipulating the contracture tissue, as well as acting neurophysiologically through affecting the central nervous system. That's really amazing. All right. But associated reactions may be elicited by fear of falling due to the lack of balance. Even meeting strength people may elicit the associated reaction. And if people have difficulties in communication and speaking with others, all these may cause associated reactions occur in stroke patients. But what Bobat suggests to control the associated reactions? Bobat suggests to control the associated reactions, ask the patients to perform their movements first slowly and gradually and step by step with controlling the associated reaction to increase the skeletal movement. Therefore, in such patients that associated reaction is elicited easily, you need to ask the patient to get relaxed, to perform the movements and their functions slowly. I'm asking you another question. I'm walking the person with a stroke. Alireza is walking, all right. Want to talk to you, all right. Want to talk to this patient, but due to the aphasia, cannot communicate with you, cannot speak, talk to you. You see that the hands, the arm posture will be raised like that. He cannot speak with you. All right. Why this happens? The affected arm posturing will be like that, will be increased like that. He cannot speak with you as a physiotherapist. All right, as his therapist. And we will see that the arm, affected arm is raising upward, like that. What's the reason for this reaction? she, as a visitor, asking me as a patient with a stroke, what happened to you? You got stroke. And she noticed that my hand is raising upward and the spasticity level increased when she asked me this question. What happened to my affected arm? That this raised came upward.
Contraction in a long time because
What was the problem?
citation-
What is it?
Contraction.
One term. Two words, of course. Is that this moving the arm upward is an associated reaction. I'm walking, but due to the fearing of losing my balance, you will see that I cannot walk. You ask me to stand and walk. All right, I fear to stand and walk due to the lack of balance. And you will see that my affected leg stiffens, my affected arm stiffens and move and raise, come to the upward position like that. I cannot walk and stand. What is the reason for these reactions? Anyone, what's the reason for these reactions? Associated reaction. All right. In normal subjects, instead of associated reactions, there are some synchronic movements. Instead of associated reaction, there are synchronic movements. They are associated normal movements, as you see here in this figure. They are normal movements of both limbs. Activity of one limb helps the patient to strongly move the opposite, for example, arm. These synchronic movements are observed when normal subjects are learning new and difficult functions and skills. But already described the asymmetrical TNS. As I defined it, asymmetrical TNR is a reflex integrated in the brain stem level of the brain stem level of CNS maturing in infancy that influence the distribution of tonus and posture of the patients with spastic limb. Instead of spasticity, asymmetrical TNR can be seen immediately. The tonic asymmetrical TNR and associated reaction can have interaction in patients with stroke. For example, if you rotate the head towards the affected upper extremity, and at the same time, if you ask the patient to perform a resistive movement with the intact hand, the interaction of associated reaction and asymmetrical TNR will enforce the extension pattern of the affected arm. But if you turn the head towards the intact side and perform a resistive exercise with the intact arm, we increase the flexion pattern on the affected arm. Therefore, associated reactions and asymmetrical tonic neck reflex may interact with each other depending on the direction of the head rotation, the flexion pattern, spastic pattern can be reinforced, or the antagonist pattern of extension may be elicited if the head to be rotated towards the affected cell. Therefore, these two reactions, associated reactions and asymmetrical TNR, can interact. And depending on the head rotation, can have different effects. But positive supporting reaction is a spinal, is an infancy reflex. Usually will be integrated 2 months after childbirth, but may persist maximum for 9 months after childbirth. But after stroke, this reaction, this positive supporting reaction, reactivate. Therefore, it's pathologic for an adult patient with a stroke. With positive supporting reaction, flexors and extensors of the leg simultaneously contract, that stiffens the affected leg that already has extensor spasticity. Therefore, the antagonistic muscles exert a synergistic function with the prime mover that results in the fixation of the joints, and in simpler terms, in positive supporting reaction, there is a co-contraction of flexors and extensors that help to stiffen the affected leg. But this stiffening of the leg with extensor tonus of the affected leg reinforced with positive supporting reaction can help, of course, to the patients with standing, although the mobility is reduced, but can help the patients to be able to stand on their legs. Therefore, in patients with a stroke, the extensor tonus of the affected leg associated with positive supporting reaction can exaggerate the spastic response on the affected side. The reason for PSR, or positive supporting reaction, is a proprioceptive stimulus due to the stretch of the intrinsic muscles of the foot, and there is also an extraceptive stimulus due to the contact of the pads of the foot, sole of the foot with the ground. Any question about the abnormal postural reflex mechanism? No? All right. What time is it? 10 minutes left, all right. Let's wait for 10 minutes and then you can rest, all right? You agree with me?
يعني لا نسمع لا
CD ليش مش اليوم؟
حتى هو يجي يوم ما يروح شنو؟
CD
انت قول له ثانية هو تعال احمد شادي
Alright, let's continue for 10 minutes and then you are allowed to rest or we will have a break. Alright, the persons with a stroke have additional problems. Listen to me please. What are you doing with your mobiles and smartphones? Listen to me please, just for 10 minutes for this session. They have additional problems. Non-weight bearing on the aquatic side. Why they suffer from non-weight bearing on the affected side? They have sensory problems, sensory loss, even vision, hearing, proprioception, and touch. They may suffer from neglect or any anesthesia, forgetting the affected side, upper and lower limbs, and they fear due to problem with sensory loss, the lack of equilibrium and right reactions, and the lack of protective extension reaction. And some people also suffer from cognitive and perceptual problem. They may suffer also from visual perceptual impairments such as semianopia. The person with a stroke, when you gave him the food, you got that half of the plate has no food, but the other side is not. What is the problem? When you ask the patient to draw the clock, he did like this.
Because he see just half of the
What's the problem with this patient?
visual problem means he saw just half of the part. Half.
What's the name of this pathology condition? It's a vision problem, it's a perceptual problem. What's the problem with such patient? He ate half of the plate, the food on the, for example, in this subject, the right side is empty, no food here, but the other side is not seen, is ignored actually. What the problem with this patient, with such patient? Why this patient draw the half of the blood and ate the half of the food on the plate? What's the name of this pathology?
Aphasia.
Homonymous hemianopia. Also, such a patient may have hemianesthesia. Hemianesthesia, ignoring all objects on the affected side, even ignoring the body segments, half of the body on the affected side is ignored. Therefore, such a patient must be examined for hemianesthesia and homonymous hemianopia. That's the vision problem.
What about
Hemianopia.
cognitive defects?
According to Bobat approach, major problems in people with strokes are lack of postural control and spasticity. She believes that spasticity causes abnormal sensory feedback to the central nervous system and can contribute to the weakness of antagonist muscles. And finally, if not managed, can cause contraction, pain, and fear. And there is such a relationship among spasticity, pain, and fear. Spasticity, especially if severe, can cause pain, and pain can cause fear. And there is a vicious cycle. Therefore, spasticity to control, to break this vicious cycle, we must reduce and manage the spasticity to control pain and fear of the patients with a stroke and spasticity. What factors can influence severity of spasticity? Emotional stresses, physical force, temperature, and rate of activity can increase the spasticity. But one important feature of the spasticity is that spasticity can be controlled, can be reduced, and can be managed. All right. It's the break time. And the next session, I will introduce the evaluation components based on Bogat approach. We have